Receiving a diagnosis of early age onset colorectal cancer can be extremely difficult. In this session, we'll explore early age onset colorectal cancer from both a clinical as well as a lived experience perspective, highlighting the emotional, psychosocial, medical, and system level challenges and opportunities that actually can be transformative. We have 5 panelists with us today, and I'll begin with Dr. Perry Tuttleman, who is a clinical psychologist, an assistant professor in the Department of Psychology at the University of Calgary, and chair in transdisciplinary digital mental health. We're also joined by Dr. Petra Wildgoose. Thanks for joining us again this year, Petra. I really do value that you continue to participate with us at this conference. Who's the lead at the Young Adult Colorectal Cancer Program, ADET Cancer Center at Sunnybrook Hospital, or Sunnybrook Health Sciences Center here in Toronto. Melissa Groff, who's a patient advocate following her diagnosis with stage 3 rectal cancer in 2023. And Melissa, thank you so much for being a co-chair of this conference as well. Kaya Svensson, who is a cancer survivor, advocate, and registered nurse at Vancouver General Hospital, and she uses her personal experiences to guide a future with better outcomes for cancer patients. And last but not least, we welcome Amanda Bradley. In 2024, Amanda faced a life-altering challenge with a cancer diagnosis, an experience that ignited her passion for advocating change. This led her to found the MedWell CB app, which Amanda would really like you to very much talk about in this session, which is an innovative platform designed to empower individuals to take control of their medical and wellness history. Thank you all very much to be here. Dr. Wildgoose, I'm going to start with you. And why we're talking about early age onset colorectal cancer, how is this different? And maybe you could just frame why there's a separate conversation versus what I'll call just colorectal cancer in general.
Yeah, thank you so much, Anne-Marie. So as you may or may not be aware, there is an increasing incidence in colorectal cancer in patients under the age of 50. And this has been steadily increasing since at least the 1980s. And we do not know why. The reason for this is still a mystery. And it's concerning because we know that there is some risk factors that are starting to be identified in terms of what may be the cause. So for example, our diets, sedentary lifestyle, obesity. We're starting to learn about the microbiome and how that might play a role in the development of early age onset colorectal cancer. But the truth of the matter is that we do not know why there is this increasing incidence. And in medicine, when we say that, what we're really saying is there's probably multiple reasons why we are seeing this, and we need to learn more. We need to do more research studies to figure out why this is happening. Unfortunately, in younger patients, we're seeing patients that are diagnosed at later stages. So 75% are usually stage 3 or stage 4 upon diagnosis. Approximately 80% are symptomatic upon diagnosis, meaning they're having bleeding or fatigue or they're anemic, certainly changes in bowel habits, for example. And because they're later stages of disease upon diagnosis, it means that they're requiring increasing treatment in terms of frequency and the complexity of its treatment. And when we have more frequent treatment or more complex treatment, there's increased side effects for patients. So younger patients are receiving treatments that are increasing side effects, but are also not just, months long, but months to years long in terms of what they require to treat their disease. And it therefore really impacts a patient's life. No matter what age you are, if you were diagnosed at stage 3 or stage 4, that's very, alarming and overwhelming. And to have those treatments, no matter what age you are, is obviously psychologically has a huge impact. But you can imagine if someone's in their 20s, 30s, or 40s and has to have, undergo this diagnosis and treatment at such a young age, you can imagine that it might be very different for them compared to somebody in their 70s, 80s, or 90s. And what I'd like to point out is that in the majority of patients that receive this diagnosis, unfortunately, we do genetic testing in all patients under the age of 50, but 80% of people, it's sporadic, which means that there's no hereditary or familial, it wasn't passed down through the family. So it's a sporadic thing that's occurred in their life, which gives them no explanation as to why this has occurred. So the psychological impact, which is what we're going to be talking a lot about today, is huge, especially upon initial diagnosis. And then, of course, their journey throughout their active cancer care and even into survivorship. Throughout their cancer journey, there's a lot of unique needs that need to be addressed in younger patients, which is also why a colorectal cancer diagnosis in patients under the age of 50 is very different than a diagnosis over the age of 50. So, for example, patients between the ages of 18 and 50, they're in a developmental stage in life that results in them having unique needs. So, for example, they're beginning to live independently, they're establishing new relationships, they're starting to have families, they're continuing with ongoing education or just starting their careers. So this is a time of constant change in their lives. And then if you add a cancer diagnosis onto this, it can be extremely overwhelming. So we need to address these needs so that patients can manage their diagnosis and undergo their treatment, but they also can continue on with their lives, which are extremely busy, with the best possible quality of life that we can give them. So there's really multiple factors that are at play, and we need to be able to address this population at a developmental level with respect to the needs that they have as they undergo their cancer treatment.
That is such a beautiful summary. Thank you. So more people getting diagnosed in more advanced stages younger, at a time in their life when there's so many other things happening and the complexities are high. This is why we're talking about this today. I probably very simply stated that, but I would like very much to dive into that conversation with the three patients that we have with us today. So between Melissa, Kaya, and Amanda, and Kaya, I think I'm going to start with you, is receiving this diagnosis at a time in your life, and I think you were 23 when you got it. You'll correct me if I'm wrong.
Yes, it was the day after my 23rd birthday.
Yeah. Can you describe what that moment was like, and how you, in fact, started to deal with that and cope with that very early stage, that diagnosis at a very early stage of life?
Yeah, so when I found out after having a colonoscopy. So I was symptomatic. I was having blood in my stool. I was having very frequent bowel movements. So I knew that something was wrong. But the GI that I had spoken to and who performed my colonoscopy had thought that I had inflammatory bowel disease, most likely ulcerative colitis. And so when we were doing the scope, it was very evident that something was not right, the way that she was speaking and acting, and then told me to tell me when my mom was the person who was going to pick me up, to tell the nurses when my mom was here to pick me up. So I knew that something was wrong. And so the GI spoke with us and said, well, you don't have any inflammation, but you do have a tumor. And we don't know until the biopsies come back, but it looks like cancer, and I think it's cancer. So it was very shocking. I didn't think that that's what was happening, and neither did the doctor that was doing my scope. She didn't think that that was what was happening either. But my mom was there with me, so she found out at the same time that I did, and we called my dad on the way home. And yeah, I mean, it was pretty a lot to process right away. But the doctor set up an appointment with a general surgeon for the following day, and he was kind of able to go over a little bit about what the next steps would be. So getting some more scans, some more blood work, basically just figuring out what the next steps were. And that was really my biggest question when I was first told it. I all I could think of was, okay, well, what are we going to do about it? What's next? what is this? What's going to happen? So it was a right away, just kind of an action thing of what am I going to do next?
Just moved right into action. Was there one thing that helped you in those very early days to cope?
Yeah, I mean, I was certainly very well supported by my family. I initially had only my immediate family knew, my parents and my brother, because I really wanted to know a little bit more, because that's the first thing that people ask of, well, what's going to happen? And that was really the first thing that I wanted to know too, of what's going to happen. And I felt very, very supported by my healthcare team, the GI doctor who originally told me, and then with the general surgeon. I felt very supported, and having a background as a registered nurse, having a little bit of knowledge around the healthcare system, I trusted that I would get the care that I needed, and that I trusted that the people that were taking care of me were very knowledgeable.
Yeah. Thank you so much. We're going to come back and pick up on a lot of the different things that you said, but Kaya, I'd like you to answer the same question, is really tell us a little bit about yourself, the early diagnosis, what you went through. What are the one or two things that helped you, at least in that really initial phase of things, to cope a little bit? Kaya? Oh, pardon me. My mistake. Melissa, I wanted to go to. Pardon me.
No problem. So I have a similar scenario to Kaya where I had symptoms. I had just had my third child, and I found out I had a hemorrhoid. And then I realized, going through maternity leave, my body was changing so much. I noticed a change in bowel habits. I had blood in my stool. And I thought maybe it was hemorrhoids that I didn't know about. So when my daughter turned 1, days later, I had my first colonoscopy. No family history of colorectal cancer. I didn't even know what colorectal cancer was. Like, it was something that I never really heard about. And so I remember the night before my colonoscopy looking up, could it be something like irritable bowel syndrome or something else? But cancer never really crossed my mind. And when I went for the colonoscopy, I remember hearing all the other patients getting dismissed by the nurse. And in my case, the specialist said to me, "Is your husband coming to pick you up?" And I said, "No, he's actually home with the kids. My in-laws are coming. They're probably already here." And sure enough, they were. And he said, "Is there any way your husband can come?" And right away, I knew something was wrong. My in-laws came, and he said, very similar to Kaya, he knew it was cancer. He took a biopsy of it, and he said, "I've already connected with a surgeon. They'll contact you tomorrow, and we'll figure out next steps." And it's like this whole shock of, oh my gosh, I never expected to hear those words. I don't even know where to begin. I don't know anyone personal to me that's gone through this. And I have 3 little kids. And I thought I was living a relatively healthy lifestyle. So there was a lot of that immediate shock and emotion, and just trying to navigate the next steps. There's no book that they hand you that says, "Here's your diagnosis and these are the next steps to follow." And, I really look for that playbook concept of helping people go through this diagnosis and understanding the different types of doctors you can work with and the different support systems you could have. But I definitely didn't receive that off the bat. It's something that I've been learning about throughout this journey.
Mm-hmm, mm-hmm. Thank you. And it really speaks to what Dr. Wildgoose raised, which is the sporadic nature of the early onset colorectal cancer. Melissa, Amanda, I wanted to go to you now and ask a similar question, which is really just talk to us about your diagnosis, the moments, and what was going through your mind, and some of those things that gave you that ability to cope at the front end.
Absolutely. So similar to Kaya and Melissa, I had I had just had my daughter probably the year before. She was about 1, and I had some bleeding in my blood in my stool. So I went to my GP. She checked it out. She thought it was a hemorrhoid. We didn't find anything. Sent me on my way, and it had subsided. So I just assumed, okay, it was nothing. And then it returned. I guess it had returned, and so I let it go on for longer than I should have. I was like, oh, okay, this is probably just an internal hemorrhoid or something, it's not a big deal. And then it wasn't going away. And so I went back to my doctor, and she was like, okay, well, I've already checked how far I can check, basically. So let's send you for a colonoscopy, and we'll see what it is. Again, I've never had any illness in my life, no track record in my family to my knowledge. So I was not expecting I wasn't expecting anything, really. I even made the joke in the endoscopy clinic. I'm like, oh, this is like the spa. I'm going to have a little nap, put a warm blanket on me. And then, seemingly what felt like 6 seconds later, I'm awake. They roll me into the recovery. They move me into a little office where my husband came in. And the doctor, she said, okay, so I met this woman for maybe all of 1 minute. When she came into the room, that was it. She said, without even looking at me, we had masks on at the time. And so she said, we removed some polyps. We found a tumor, we found something which is most probably a tumor, most probably cancer. I'm referring you to Sunnybrook, Dr. Ashamalo, someone will call you, and I was just sitting there thinking, what the hell did she just say? Like, what is happening? I had thought this was, going into that room was just part of the routine of the discharge from this experience. And then we're just sitting there, and she kind of caught a glimpse of my reaction and was like, oh, sorry, do you need a minute? It's like, yeah, I need like more than 1 minute, more than 1 minute. And I just remember I was so mad at her. And at this point, I'm extremely grateful for her and her expertise and the fact that she caught it. But I just remember thinking, like, how you break this information to someone who has no idea that they're going to walk out with this new information? So we left that appointment, and I was immediately in a fear-based reaction. I was like, we're not talking about cancer in our house. We're not using the C word. I'm not sick. This is not not that it's not happening, but we're not going to let on that this is happening. Which was held on for, a little while, because at the beginning, it's like a hurry up and wait situation. You're waiting for someone to call you to tell you what's happening. But then they say, okay, we'll call you in, after you get your tests, then we'll call you in 3 weeks from there, or whatever the time frame is. Like, it was quite a significant time frame. So my initial appointment was on the 31st of January, and I didn't speak to my surgical oncologist until the 19th of March. So in that time, I'm just like, what's happening here? And you go into these spirals. And fortunately, I have a friend who's a cancer survivor, and immediately I called her and said, I need tools. What do you have for me here? And she said the best piece of advice that I got was from her. And she said, you need to try to focus on your healthy cells, because you've got a full body of healthy cells. You've got to just keep grasp of that. It's not like, don't have to go down this kind of rabbit hole, right, of Google and all the things. And so that really stuck with me. And that was kind of what took me out of the shell of the fear of then saying, okay, what if we're just a little bit curious about what this all means? Like, the only people that I had known to that point that had cancer other than this friend, had passed away from cancer. So I was mortified. It's like, this is serious. I mean, and I'm not suggesting it's not serious, but I thought I was going to die. And, that keeping the focusing on the healthy cells and also being curious about it all made things a little bit more open for me, made the pathway a little bit clearer at the beginning stages.
Yeah, and a very tough place to get to in the moment. Dr. Tuttleman, you've been so patient. You've been nodding through most of these conversations. I wanted to bring you into the conversation. So much going on. when people are first diagnosed, just the shock, the difficulties. Can you give your perspective here? You must hear this frequently, and it's common.
Absolutely. I think, a common thread between what Melissa and Kaya and Amanda spoke about is that mix of emotion that you're going through right at the beginning, right? And it's so common for patients to experience any spectrum of emotions when they get a diagnosis of cancer, whether it's fear or sadness or anger. Maybe it's a bit of shame or guilt around what this is going to mean for themselves, for their family, maybe around that delay in seeking care. All the emotions that sort of come around with that are also common. Other patients might feel numb. Like, it's completely normal to also feel numb and just not know what you're feeling given the overwhelming nature of what you're experiencing. And it's completely common to fluctuate through those emotions as well. I think what Amanda touched on, the focusing on the present moment, the focusing on the information we do have, what we do know our next steps are going to be, are so, so important, because we could go down every rabbit hole of what ifs. And until we really get the information from our providers to guide us on those next steps, the best thing that we can do is really stay present in the current moment.
Thank you for that. Outside of what I call managing the physical side of things, I can't imagine how intense the emotional, psychosocial side of this is. And it doesn't oftentimes get discussed as much as it needs to be. And I want to come back on a couple of core issues around that. Before we do, Dr. Wildgoose, I want to go into this concept of how you navigate the system. And with the young folks in this panel touching all aspects of their life, and how does the system generally support people who are at this age entering into a cancer diagnosis? How are they surrounded by the system, if I could use that word, to be able to help navigate, get the physical care, the emotional care, the psychological care, et cetera, et cetera? Is the system set up to support them that way?
That's a very good question. So I have a few things I'd like to just mention. Just going back to what you've talked about, you've mentioned again, and all of you have mentioned is sort of the physical and the mental journey. And so with every single patient that I see, every single young adult patient, upon initial consultation, that's really what I stress is we can take back some control. I think a lot of patients, maybe 100% even, I would say, feel a loss of control with their diagnosis over their own bodies. And so Amanda sort of mentioned it, right? Like taking back that control by focusing on what you can control with respect to your physical and your mental health. And I always say, it's a quote from the first director of the WHO, but basically it's along the lines of, if you don't have your mental health, you can't have your physical health. And so I really try to empower patients to focus on both of those things upon their diagnosis in whatever way they can. So when we're talking about unique needs, it's things like focusing on sleep, diet, exercise. It's focusing on their mental health journey and what that means for them specifically. And there's a lot that patients can take back and work on as they move through their journey. But it's difficult because they don't always have someone like myself who can help them work through that physical and mental health journey. And unfortunately, our system is, as we all know, is quite fragmented and siloed. So the oncologists, so a lot of oncologists are fantastic, but as Amanda already said, with respect to the gastroenterologist's focus is to diagnose and send you on your way. That as much as somebody might like to be able to spend the time, to address Amanda's, mental health reaction appropriately, rationally in response to her diagnosis, whatever the restriction is, they just can't. So whether it's time or whether it's, the clinical acumen, and that goes for everybody within our healthcare system. So every surgical oncologist, radiation oncologist, medical oncologist, and even the family doctor, right? So I find often that younger patients, because they're in a specific developmental stage, they're not a pediatric patient under the age of 18, and they're not over the age of 50. They're not retired and, expecting a cancer diagnosis potentially if you're in your 80s and, 70s or 80s. We're not really addressing this population. They're kind of stuck between the family doctor and all the oncologists who, as I mentioned, don't always have the time or the ability to address all these other aspects of really the human experience. That's what we're talking about here, right? And we could address this in a lot of patients. Doesn't matter what the diagnosis is. We're talking about the human experience with respect to a cancer diagnosis and what suffering really is. And yes, suffering is universal, but I always like to say suffering is very personal at the same time. And we just don't have that capacity. What is added on to that is the fact that younger patients, it's generally their first time being exposed to the hospital system. They may have been to their family doctor one or two times for screening, like pap tests, for example, or, a check for moles or whatever. But to really be then thrown out of nowhere into the hospital setting is very overwhelming. And one of the things I commonly hear from patients, whether I'm, on a conference panel or I'm talking to a patient individually one-on-one, is that patients feel very isolated. And I can give you a list of a million things why it's very isolating for younger patients. But one of the major things is just sitting in the waiting room for chemotherapy or in the chemo suite, getting the chemotherapy because they are the youngest patient in the room. So we don't have these centers yet. We don't have the capacity yet to, have specific locations that can just tailor to patients between the ages of 18 or 39 or 18 and 50, for example, in our situation. But I mean, Perry Tuttleman's been very involved in this, and I think there's a lot of work being done now to try to establish AYA clinics to better address these needs in younger patients. But it's a work in progress, and I definitely think that forums like this are really valuable for that reason, because we don't want patients stuck between the two, right? We don't want them stuck between the family doctor and the oncologist. We need a space for them to exist. And that space, again, is acknowledging their physical and their mental health, all aspects of their cancer journey.
Thank you, Petra. Melissa, maybe I'll ask you, you're a young mom. It's a load of stuff going on at a certain age. Young families, starting some careers, you've never dealt with the hospital system. It's layer and layer and layer at an early age where you haven't had previous experience. Like, how did you attack this? How did you start in a very systematic way? Or maybe it wasn't even systematic. It's like a day by day, step by step. What advice or what was your story around how you tackled this in a way that would be helpful for others?
So the feeling of overwhelm is real. And when you think you have a busy life before you have kids, then you have kids and you're like, wow, I have a really busy life now. And then you have kids and then you have a cancer diagnosis and you're like, okay, here we go. And it's not something that I wanted to bring me down. I tried to look at this, and I call this the biggest project of my life. Thinking back in university, you would spend hours studying. You would spend hours on projects and days and weeks. And I thought, okay, how am I going to do this? How am I going to use my time wisely? Who am I going to talk to? And immediately I thought of a couple of people in my life that were affected by different types of cancer. And I thought, let me see what they did. What types of advice do they have for me? Anywhere from questions to ask the doctor, printing off your scan results, starting a file folder of things, taking notes, recording your appointments. All of these like little bits of information gave me the power. When we talk about having control, those were things that I could control. And I think when you have a diagnosis, probably of any type of diagnosis, you feel that loss of control because you don't know what to do. And especially from my perspective, I don't have anyone immediately close to me that I could say, oh, I remember so-and-so did all these things. So, having some of those conversations with people that I knew really helped me, especially when people would stay positive. So to Amanda's point of like thinking, almost like you're almost in denial to a degree where you're like, I'm not accepting this. I don't have cancer, right? Like it's almost like being in that mindset. Hey, I look good. I feel great. yeah, I had some symptoms, but other than that, I have nothing to believe that something's really wrong with me. I just try to really stay in that positive mindset. And I think even today, almost 2 years later, I'm looking at my journey and thinking about how much I've learned and I'm continuing to learn. And you modify as you go. And a lot of people look at me and say, I don't know how you do it. And I say, I don't know how I wouldn't do it, because it's like you're just tasked with something and you just got to get it done. And it's uncomfortable and it puts you in these weird situations. There's pain, there's heartache, there's happy moments. You celebrate the small wins. Yeah, that's, I think, the advice I can give. And I just kind of smile.
Yeah, I'm laughing when you use the word project plan, because Dr. Tuttleman, I'm not sure everybody has that wonderful capacity to know how to do a project plan and to get out the Excel spreadsheet and keep notes and do all of that kind of stuff. So is there a pathway here that you advise people to accept and go on? I know everybody's path is a little bit different, but it's how do you get your head around this overwhelm, especially if you don't know how to do a project plan?
It's a very good question, and everybody's experience is going to be so different. And I will say every hospital, every health center, every health network is also going to be different and have a different pathway and need a different set of navigation and skills, which can be quite frustrating at times, because something that someone got access to in Toronto might not exist in Calgary or vice versa. So it's needing to be flexible in terms of navigating that. But I think a challenge that a lot of young patients run into is that you don't know what you don't know, right? Especially if this is your first time navigating the healthcare system in this way. And so some important things to think about and to ask for: some hospitals and programs have patient navigators specifically for certain groups like adolescents and young adults, Indigenous patients, patients with advanced metastatic disease. These are specially trained clinicians that sort of help patients navigate through the system. Again, some hospitals will have them, some won't. Some hospitals will have social workers and psychologists able and available to consult with patients around needs like emotional adjustment to cancer, financial resources and supports. Oftentimes they require a referral, but if you ask your team, many times the team's like, oh yes, absolutely. It just may have not come up. So don't be afraid to ask about that. Same with rehabilitation support. There's often occupational therapists, physiotherapists who are able to help with post-surgical rehabilitation or other types of adjustments that are needed. But again, if you don't ask, you might not know. Here in Calgary, we're actually starting a new program. We'll be rolling it out over the next couple years. That is sort of a new patient diagnosis program where we provide information on all of these supports available, because we've heard time and time again that patients might go through their whole journey and not learn about these supportive care services that are available. So don't hesitate to ask, because at the end of the day, the answer might be, no, we don't have that available. Or it might be, yes, of course, I just have to put in a referral.
Yeah, no, I really like the point is you don't know what you don't know. And so understanding that there's a list of significant helpful resources and a whole bunch of different capacities, is even understanding how to get that list, I think, is hard. Kaya, this is, I think, a perfect place for you to enter the conversation as a healthcare professional, as a nurse. Were you aware of the vast resources that you were able to, if you just asked, you could get, or did you have to start from scratch?
Yeah, I mean, my background isn't in oncology, and so it was all a bit of a mystery to me. I mean, I think that an important point that Dr. Tuttleman is bringing up is just not being afraid to ask questions. And so I think that that's a really important thing to remember, that there's no harm in asking questions. And it's certainly important to write down your questions. And like, you have just a certain amount of time with your team. And so making sure that you're writing down things as they come up. or symptoms as they come up, is super important, to make sure that you're not leaving that appointment feeling like you didn't speak about everything that you wanted to, or didn't get your answers that you were looking for. So no, I didn't feel necessarily totally prepared. I don't think anyone does. I think I was aware a little bit more about how varied the healthcare system is, and how important having a multidisciplinary team is. Many people aren't aware of that, what an occupational therapist is, and what exactly does that entail. Or, one of my biggest concerns right when I found out that I had colorectal cancer was that thinking about the possibility of having an ostomy. And I do know at my hospital, at least, we have ostomy clinicians. So knowing that is something that exists, a person that specializes in ostomy care, and having that support. So yeah, I certainly had some knowledge of what was available, but again, what was specifically available to me as a cancer patient, and what was available through BC Cancer, was curious to, or I was curious about, and then obviously the diet aspect was something that I was really having a lot of questions about. My tumor was blocking a considerable amount of my colon, and I was really concerned about a blockage in the meantime while I was waiting for treatment to start. So it was important to me that I tried to connect with a dietitian pretty early on, and yeah, that was just asking my oncologist, do you guys have dietitians through BC Cancer that I can talk to? Because a lot of my questions were just directed to my oncologist, and she was able to field those questions of, we actually have people specifically for this. Why don't I refer you to them?
Perfect.
I'd like to add on to this conversation if I could, because I say all the time, like, I provide medical care, obviously. So, I provide I address the lifestyle factors, but also, of course, sexuality and mental health and fertility. But I spend about 70% of my time, I would say, helping patients navigate the healthcare system and providing resources and supports. And this was a thing that I've learned just over time from my patients, feeling empowered, giving them the opportunity to be able to ask questions and raise their voice and to tell me what their needs are. And for me, it's very simple to help somebody navigate the system. It's very simple to, as a family doctor by training, that's what I do. I create lists of resources and supports. It's part of my job. And so that's very simple for me to do, but it's extremely overwhelming for the patient. And so the fact that I spend 70% of my time doing that means that the patient is probably consumed by that 70% of the time as well. And if that can help to alleviate some of the burden and some of the mental health impact, that's huge. So something that I can do in 30 seconds to alleviate a huge stressor or burden in a young patient's life is monumentous. But what I would like to say is that it's not that easy. It really isn't that easy to always navigate the resources and supports. I'm still learning myself that these resources and supports exist. Patients are so, young patients I find are far more empowered and are self-advocates, and that's a whole other thing we could talk about, is that fair to the younger patient? But I do find that younger patients, have to self-advocate and are more empowered. And so patients actually come to me sometimes and say, look at this amazing resource that I found. And I'm grateful to them because then I can add it to my list. But there are these resources that exist, but it's still difficult to navigate that, right? There's things on the hospital level, on the regional level, on the provincial level, on the national level, and they exist through many different forms. And that's part of the stress, right? A patient will sit at home and say, I need X, Y, and Z for my child, or I need it for my parent. This population is not just taking care of kids, but they're older parents, right? Who may or may not have their own healthcare needs. So they can get lost in the internet very quickly, hours and hours of time that are wasted to try to find resources and supports. And so it is very helpful if you can ask a provider, as Kaya has said, and they can refer you, but that doesn't always necessarily happen. So that's also one of the other struggles. That's one of the time-consuming things that can have a huge impact on a patient's quality of life.
Yeah, thank you for reinforcing that. And I think it's a perfect bridge into some of the, Amanda, you took it to another step. You have an app, and we don't know much about it, but certainly you wanted a place to minimize, to at least collect some information that helped you to track and project manage your illness, so to speak. So tell us a little bit about that and why you actually created it, what it can do to help others.
So it was in the full-time job of being a cancer patient, it was really, Dr. Wildgoose was on maternity leave, bless you, but was not available in the program that I was in. So didn't have all those resources at the ready. So I really went hard at researching, and I like to try and do things. As I said earlier, I was looking at myself holistically, like how do I take care of my whole body? And so I have a naturopath. I went to an Ayurvedic practitioner to experience like what is their idea of how can we come at this from all angles, right? It doesn't just have to be one-sided. And what I found is that it became really complex when you try to introduce some other wellness practices in from the medical side of things. Some of my medical practitioners weren't very open to these other opportunities or options on how I was kind of taking care of my well-being. And not that they were against it, it just wasn't an open conversation. And so I found it very complex to be able to, keep track of the supplements I was taking and these appointments while also navigating my medical appointments at the hospital. And I thought, like, how do people, short of a file folder, like, how are we keeping track of all these things? Like, I have to log into my chart to get this information, Life Labs to get this information, my Jane app. I'm like, there's already enough stress going on. So the thought about MedWell CV was that, we all have a career CV and we keep track of our jobs for our life, or like to prove that we've worked somewhere, or our accreditation. But we don't do that so much with our health. We put our health in the hands of, whether it's the government or the hospital or whomever, like it's somebody else is going to have this information. But then in a time of need, when it's extremely stressful, for us to remember those things or access those things, it can be even more complex. So and I would be in appointments, not only for me, but the little lady beside me, someone would ask her, well, what medications are you taking? And she would say, I don't know, let's call the pharmacist. But there's nobody has time. There's not enough time in a day to do all those things. So that's kind of how the app has been born, with the idea that to empower people to have their information, to be able to find the resources that they need, or to support them within these journeys, in any kind of treatment plan or just day-to-day healthcare, so that there are resources, so they don't have to go digging and like sifting through all the things. Because as we know, it can be very complex, and you can try on one thing and it may work for you, but it may not work for you, or maybe someone else. And it's not a one size fits all either, right? Like everyone's diagnosis is different. Everyone's journey is different. So, I mean, I think that's one of the takeaways really that I found very important, is that initially when I heard the word cancer, I just thought, I don't know what I thought. I just thought cancer. That was just like this very broad thing, very scary, very just like straight line. And after going through this process, I realized that it's so different for everyone. And, the common questions of like, well, what stage is yours, or what type of cancer, or, all the nuances in between we don't, if someone told me they're stage 2 rectal cancer, that could be different than what I experienced, like we may not have the same thing, but we try to latch on to identify, to feel a part of something. And I think that sometimes we lose our internal focus and the way that our intuition works to do what's right for us.
Yeah. And I just get you to give a shout out to your app. How do people get it if they want to take a look at it?
It's not quite launched yet, so it's
okay. Well, stay tuned then. Colorectal cancer will be very pleased to help you with that. I want to bridge the conversation, Dr. Wildgoose, Dr. Tillerman, to the issue of fertility, sexuality, intimacy, which is, I think, very particular to early age onset colorectal cancer. And maybe, Dr. Tillerman, I'll start with you. The let's call it the intimacy side of the sexuality side of it. Surely that is a very big thing on people's minds. Can you talk about that a little bit? Some of what you've seen, what people go through, and how they should start to reframe all of this.
Absolutely. So sexuality, intimacy, those are all pieces unique to the early onset age group that are impacted by the cancer experience. It's not uncommon to experience declines in desire or drive, especially during times when you're feeling extremely stressed, overwhelmed, going through bodily changes, right? There might be surgical scars, surgical changes that impact your well-being, your energy. So it is completely normal wherever you're at, sort of on that range of desire and interest in terms of sexuality and intimacy. It's really important to be able to have open conversations with your team, with your partner, about where you're at. And of course, these are topics that clinicians don't always feel comfortable bringing up with their patients, and patients don't often feel comfortable bringing up with their providers, so can often lead to a bit of a conspiracy of silence, if you will, and shame related to some of these topics. And so I always encourage patients that I'm working with, if they're comfortable, to really bring this up with, whether it's a nurse, whether it's their physician team, to really say, hey, this is something that I'm really interested in talking about, because it's important to find out the medications that you're on, if there are important considerations around that, and sexuality and intimacy, and as well as any specific supports that might be available at your center.
Dr. Wagos, is there clinical things that people who have early age onset colorectal cancer need to know about, to think about? How do you frame the fertility conversation clinically?
Yeah, I think there's 4 things that sort of need to be addressed. So as Dr. Tuttleman already said, so body image is sort of one main aspect. So all the physical impacts, so scarring, ostomies, body weight and composition changes from chemotherapy, for example, or radiation or surgery, or just having a cancer diagnosis itself. So there's a body image aspect and how we identify, because our body image has been changed from a diagnosis of cancer. There's also the fertility aspect. So we know there's been multiple surveys done that a lot of young patients are not asked upfront about whether they want to have children. And this needs to be a conversation that is had prior to the start of chemotherapy or radiation. If a patient has long course radiation, they have a almost 100% chance of not being able to have children in the future. So they need to do egg or sperm preservation prior to long course radiation. If they're going to be having like continuous chemotherapy, depending on how much chemotherapy they're having, there's also a chance that they won't get their fertility back. So there needs to have the conversation up front as well there. But even short course radiation can result in, depending on a patient's age, and then if you add on chemotherapy as well, there's the possibility of going into becoming infertile as well. So I always, again, it's what Dr. Tuttleman already said. It's a very topic that patients don't always want to bring up. It's sensitive. So depending on how the conversation is going, it really needs to be brought up, so we can manage expectations up front. And I don't necessarily care what the patient's journey is going to be, whether they're having radiation or chemo, because plans may change. Every person's journey is different. Pathology might change, which might change the direction and then require you to have chemotherapy in the future. I think in every young patient, they deserve to have that fertility conversation as soon as possible, as soon as they're comfortable. And I encourage patients to, again, self-advocate, to bring up the topic, because unfortunately, patients don't always get that opportunity. And I have seen a situation where they haven't had the conversation up front. They haven't realized that they would become infertile from their treatment, and they obviously would have wanted to have children in the future. So this is a conversation that needs to be sort of the big conversation that needs to be had as soon as possible. But there's also the sexuality and sexual health impacts that need to be sort of secondary to that. Just knowing that, in men, there could be issues in relation to semen, and in women, there can be issues in relation to, vaginal dryness, vaginal shortening, so many symptoms in relation to basically having radiation, for example, and even chemotherapy or surgery, depending on the surgery itself. So this needs to be brought up as soon as possible. Again, a sensitive topic, but as soon as possible. And then another big sort of the fourth thing is premature menopause in younger patients. We're talking about women, obviously. If they've undergone any kind of radiation, there's a high chance, and even surgery, there's a high chance they're going to undergo premature menopause. And even chemotherapy, I think I said surgery, but any kind of radiation or chemotherapy, there's a high chance they'll go into premature menopause. And this needs to be addressed. There's multiple things that can be done to treat premature menopause, but really it's replacing hormones. It's giving back the patient the hormones that they've lost as a result of their radiation or their chemo. And it needs to be treated to the average age of menopause in the general population, which is the age of 51. And I always do a shout out to all of this because it's extremely underaddressed. I've seen so many women who have been in menopause. Their family doctors aren't aware that the doses are higher for premature menopause than patients that are in menopause around the age of 51. And if your family doctor isn't aware, then to see a gynecologist or to go to a menopause clinic so that you can get your symptoms treated, because again, you've gone through this whole cancer diagnosis and active treatment, and you're in the survivorship phase and you're still feeling awful and you don't know why you're feeling awful. And it's because menopause can impact so many different body systems, including your mental health. And so getting that addressed is extremely important prior to then, working on all the other aspects of survivorship care.
Yeah, thank you.
One thing I'll add on that I've just heard from young patients quite a bit is we're not doing a good enough job at bringing up the fertility conversation, and that needs to happen, absolutely. But then I think as providers, we also need to start being more comfortable with whatever the patient's decision is around fertility, because I've had some patients tell me like, hey, I have felt quite pressured from my team to undergo fertility preservation, and I've decided I don't want children, or I don't know if I want children, or I don't have the financial means to pursue this right now. And so I think wherever you're at is okay. And as clinicians, I think we need to, from a values perspective, be okay with where our patients are at too.
Mm-hmm. Melissa, Kaya, or Amanda, is there any comments that you wanted to add to this conversation on fertility, sexuality? Your own experiences or advice?
Certainly a really, really important thing to be discussing. And I was lucky enough that my radiation oncologist brought it up immediately. And I relate and resonate with a lot of what Dr. Wildgoose was bringing up. I had 25 sessions of pelvic radiation, and I was told pretty certainly that I would go into menopause, premature menopause, and that I did do fertility preservation before I started. Unfortunately, I had a bit of poor results with that. I only was able to preserve one egg, but the fertility doctor said that unfortunately that can happen sometimes with people who have cancer. So I was lucky that I had that conversation early on and that my clinician brought it up with me. I didn't have to self-advocate for it. And then they offered me those opportunities before we began treatment. And I was lucky enough that they were upfront with me about what the possibilities were. And then I was then referred to a doctor that specializes in premature menopause and sexuality, and they were able to prescribe me those hormone replacement therapies. So yeah, I mean, it's a completely odd thing to be relating to my mom and my mom's friends more so about what I'm going through in terms of menopause and having those symptoms. It's an odd thing as a 23-year-old. And also I was single at the time that I was diagnosed, and I have always thought about having children, but in a very, long-term aspect. So being confronted very immediately with those questions was a lot to take in.
Yeah. It demanded a tremendous amount of resiliency, no doubt. Kaya or Amanda, Melissa or Amanda, in the last couple of moments, anything to add to that?
I would just say to mirror what Dr. Wildgoose said, like it's very important to, I think when I was explained about the premature menopause, it was just kind of a skiff over and I didn't really, it didn't really sink in, I don't think. And so then when I found myself having all these additional symptoms of menopause at post treatment, I was like, what is actually happening here? And so when being able to find the resources to break that down were extremely helpful. And I think that if someone's not addressing it with you, you need to talk about it. And I would also talk about the sexual health part, as it is a hard thing to talk about. I'm very happily married, but even there has been a it was hard for my husband and I to kind of break it down, because on the outside, I don't look sick, or through this whole time I've kept, looking pretty healthy, but it's on the inside. And sometimes that changes. And if you don't have those conversations, your partner doesn't know what you're going through, right? Like, yes, we are going through a lot when we're dealing with this diagnosis, but our partner is also going through something and feeling that disconnect. So I think it's really important to have those conversations. And if you're unable to facilitate them, then you can ask for help or resources to allow you and your partner to have those conversations.
Thank you. Melissa, I'll give you the last word if you would like to make one. If not, we're okay too.
Yeah, I don't really have much to comment on perimenopause. I'm fortunate that I haven't experienced that yet. But I would say I don't know enough about it. So I know if my period changes, I'll probably start, having some alarms go off and maybe ask my family doctor, does this sound like perimenopause? I've heard that it's on the rise in young people, like outside of the cancer world. But I don't know very much about it. And again, it's not something that was really discussed with me when going for treatment. The doctor didn't sit down with me and say, by the way, you could experience all of these things. So, yeah, I really hope that through advocacy and a clinic like where Dr. Wildgoose is at, we can get more information to young people. And I think that goes like with all information, not just on sexual health and menopause and such, but just from everything about educating people on the importance of going for a colonoscopy, advocating for themselves, and listening to your body.
Thank you. You're all beautiful advocates in your own right. We so appreciate all of you being here. I know that we've got a ton of questions coming in on the system, so we're going to take a few minutes to address all of those questions now. I'm absolutely thrilled to say that for the question and answer session, which we're now about to have, Dr. Tuttleman, Dr. Wildgoose, Kaya, and Melissa have joined us. And it's really great to see that we've got so many fantastic questions coming through the question feature on the platform. Thank you so much for bringing these to us. Let's get right into it. And the first question here is, how might healthcare teams be more proactive so patients don't have to figure everything out on their own? Great question. What can be done to alleviate the burden of asking the right questions from the patient? So perhaps, Dr. Tuttleman, I can start with your perspective on this. How do we alleviate the burden for patients in asking the right things?
I think that's a really excellent question. And we know the healthcare system is dealing with increasing volumes and decreasing resources. We're seeing more people needing more support with less support available. We're developing a new program here in Calgary to provide self-navigation information and tools and resources directly to patients and families. Because as we talked about in the session, patients don't know what they don't know, right? So you don't know what to ask if you don't even know what's out there. So I think as a healthcare system and as healthcare providers, we need to be doing a better job at democratizing some of the information, giving it out to patients sort of more broadly and universally, so that patients sort of know what to ask for and what to advocate for.
What a great tool. Is this relatively new, this concept of self-navigation? Do you know if it's being done in other parts of the country outside of your institution?
This would sort of be the first sort of formalized program that we're starting. It's going to be called Anchor. It stands for Addressing Unmet Needs in Cancer Health and Supportive Care for Newly Diagnosed Adolescents and Young Adults. We're just in the phases of co-designing it with patients now, but we hope that we'll be able to roll it out across the country in the coming years.
Yeah, great initiative. Keep us posted on that. Dr. Wildgoose, from your perspective, is there tools like this that exist in your institution or ways that are to offer better navigation?
I think some of the resources do exist in certain settings. I think Dr. Tuttleman touched on it. Most cancer centers do have patient navigators and they have social workers, and they do have allied health professionals that can be very helpful with navigating care. There's nurse navigators, for example, in a lot of cancer centers as well. So I do think it's just a matter of getting hooked up with those resources. So unfortunately, the burden may be on the patient to initially ask about that. But I think what Dr. Tuttleman is referring to with respect to a tool would be extremely helpful because, again, they don't know what they don't know, but resources do exist. And I think I mentioned that as well, that part of what I do is just help to find those resources because there is resources out there. It's just a matter of finding them.
Great. And if you're anyone in our audience who might be feeling lost, Colorectal Cancer Canada is a very helpful resource to get you to the right place as well. I'm going to go to the next question here. And Melissa, I think this one is really directed at you as a young parent going through CRC. How did you handle the challenges of day-to-day childcare, school, just being a mom, really? And what helped you most and what do you wish was available?
So, when they say that it takes a village to raise a family, it really does. And it takes a village to help navigate through a diagnosis as well. So, having my in laws close by, my husband's family all lives close to me, and then my own family would come to visit, would stay over, friends around me. Just having that sense of community was a huge help, and it continues to be a huge help, especially on days where I was going through treatment and I just really didn't feel well. I was able to ask for help to have someone else drop the kids off if my husband had to run to work early that day. So having that community is definitely helpful and supportive, and receiving help when it's hard for us to ask for help is also helpful. In terms of tools, talking about these resources that exist, including with Colorectal Cancer Canada, it's nice to have an area or a website or a contact person where you can go and ask these types of questions. If you're looking for some help on what do I eat if I'm feeling this way, or I have an ileostomy, how can I navigate life with that? And just having that support so they can direct you on where to go and where to find the information.
Thank you very much. You do an extraordinary job, and you're building very resilient children, no doubt, as a result.
Thank you.
Kaya, maybe I'll direct this question at you. Many early age onset colorectal cancer patients talk about feeling dismissed when they are getting a diagnosis, and you referenced this in some of the conversation we had earlier on. What would you suggest people start to advocate for, and how do they do that for themselves? If you can talk about how you would recommend going through what you went through, better advocacy for others who feel dismissed, that would be great.
Yeah, I mean, it's a hard situation because, I certainly didn't know what was going on. I couldn't say, I think that I have cancer, I want you to do this. But I think that it's challenging in our healthcare system. There's always time constraints, resource constraints. But I think just like pushing for all the testing available. I mean, myself, Melissa, and Amanda, who spoke earlier, all of us got diagnosed via a colonoscopy. And I mean, it's proven to save lives, and that's how all of us got diagnosed. I think there's a lot of hesitancy to refer someone to get a colonoscopy. So, as daunting as it is, I can assure you that it's well worth well worth it. So yeah, I don't know. I think that it's hard for providers to know everything and to think of every option. But yeah, I think just like asking all the questions, and if you ask directly, can I get a colonoscopy, and someone says no, you have to say, can you write down that you told me that I asked for it, and you're not
Yeah,
writing
and
me
so
a
many of
referral
the
for
other
it.
conversations that have happened in various other sessions in this conference always talk about an open door for second opinions. If something feels right, push in on that. You would
Yeah.
support that?
Which, I mean, again, unfortunately, that puts the onus on the patient again.
Yeah.
But it's certainly a hard situation.
Yeah.
But you know, with it recognizing the symptoms, if you're able to recognize those signs and symptoms of colorectal cancer, maybe your family has a history of it. You know, that wasn't my situation. My family had no history of it. But if you're recognizing that those signs or symptoms are showing up, that's going to be the utmost importance to bring up with someone.
Yeah, thank you so much for that. I'm going to direct the next question for Dr. Wildgoose. The question is, what recommendations do you have for younger cancer? Patients who are often encouraged to undergo more aggressive treatments because they were able to handle it, but don't necessarily have the long-term impacts of those treatments taken into the consideration by their practitioners. So that was, let me restate that a little bit. I think what this question is aiming to get at is the type of treatment, younger versus older, short versus long-term impacts, the kind of guidance you would offer for people with early stage.
So patients who have early stage aren't the ones who are necessarily going to have the greater short-term or long-term impacts. It's really the ones that are, stage 3 or stage 4. And yeah, I mean, the issue is that the patients are receiving the same treatment as somebody over the age of 50, but it's having increased side effects because, for example, patients in their 20s, 30s, and 40s, are still sexually active, for example. So it could have impacts on sexual health, it can have impacts on menopause. They have children. So, the long course radiation or the chemo and the radiation combined can be it's a marathon, right? Not a sprint. So it can have a huge impact on childcare. So really the impacts, the treatments are the same, and it's really mostly for, locally advanced or metastatic cancer that we're talking about, the really aggressive, longer course treatments that have the increased side effects. And then because they have the increased side effects and because they take a lot longer to administer these treatments, they have increased side effects on not just the patient, but also the patient's social life and their families. So it is certainly an issue because we know that 75% of patients are under the age of 50 are diagnosed with stage 3 or stage 4. So they are going to have treatments that last from months to years. And so it does impact not just the patient, but their families, their friends. And it is a huge issue. So it needs to be discussed. And I think that's sort of maybe what they're asking is, like, it needs to be discussed and the expectations need to be discussed up front. So they know, moving forward, what it's going to look like with respect to taking care of their children or returning to work or whatever that might look like for the individual patient, which is very different for each patient.
I think that's a very fair statement. This is a very broad-based question, and we can boil it down. The question actually is, were any of you diagnosed with Lynch syndrome? So we'll ask about that, but I think it might be very helpful while we have you, Dr. Wildgoose, can you explain really what Lynch syndrome is in lay terms? Is there a difference between other early stage cancers. Maybe just put some context around that question before we ask Kaya and Melissa to answer.
Yeah, so it's important to know that 85% of cancers in colorectal cancers in younger patients are sporadic, which means that there is no known cause. It's not hereditary. 15% we are able to find a genetic cause or a reason for it. And the majority that we find is something called Lynch syndrome. And we test at Sunnybrook, I'm assuming at most cancer centers, that's the one we test for right off the bat. So every tumor gets sent, a biopsy is taken, and it gets sent for Lynch syndrome. And it does change management for patients. So that's sort of the easy short form breakdown.
Yeah. Thank you very much. Melissa, Kaya, either of you diagnosed with Lynch syndrome?
Yes. So when I was first diagnosed, obviously, like Dr. Wild Goose said, they sent my tumor sample off to get some testing done, and it showed that I did not have any genetic abnormalities. But actually, after I had finished all of my treatment, I underwent more genetic testing, and it found that I had something called a variant of unknown significance. So it wasn't, my gene wasn't, I guess, abnormal in the normal sense of what they would diagnose Lynch syndrome as, but it did have some sort of abnormality on the same gene, the MSH6 gene. So they have decided to treat me as if I do have Lynch syndrome. So like Dr. Wild Goose says, it would have changed my treatment plan had they had known prior to my treatment. And now going forward, just be more aware of that's the other types of cancer that it predisposes me to, as well as the implications that it had for my family of then my parents getting tested, my sibling, and greater than that, my family, which is very interesting. So I live in BC, where that testing was pretty readily available. But my dad, his sister lives in Manitoba, and my dad is the one who carries this gene. She brought it up with her family physician, and they were not open to offering her the testing. It wasn't something that they routinely offered. So it was very interesting, the differences that across the country of the, I guess, power behind the genetic testing, or the amount of resources that they had for that.
Thank you for the explanation. I'm going to go to the next question here, and it starts to, I'm going to reframe it a little bit here, and this question will be directed to first Melissa and Kaya, but the idea here is that as you entered your diagnosis, what are some of the needs, if any, you wish that the healthcare system or a patient partner organization like colorectal cancer would have done for you or addressed? Was there something that you could call out that said, at the very beginning of my journey, at my diagnosis, I wish somebody had said to me, I wish somebody had given me? And then I'd like to bring you into the conversation, Dr. Tuttleman. You must hear this often in terms of what people say. So let me go first to Kaya and Melissa. Melissa, do you want to take a try at that?
Sure. So I think back to when I got diagnosed, and it was in an evening, and the next morning a surgeon called me because the specialist had gotten in touch with him that night. And I wish that instead of the surgeon being the first person to call me, it was someone like a patient advocate to say, sorry to hear about your diagnosis. These are the types of doctors that you could expect to work with. These are the areas that you may have questions about. And almost like a little interview of some sort that would ask me how I felt, what types of services am I looking for, what support do I need, do I know anything about my diagnosis, because it did not go in that direction, and I feel like I had to take a lot of that on myself without quickly starting to Google and going down Google rabbit holes.
Beautifully articulated. Kaya, do you want to build on that?
Yeah, I mean, I think something that right off the bat I was quite worried about was work. I was just at the very beginning of starting my career, and I mean, through through the process of coming off work was very, very challenging. So had I had a little bit more support in terms of like, how do you apply for long-term disability, or how do you, there's a lot of forms and a lot of paperwork involved with that. So, I mean, that's just one thing that pops to the top of my mind of, I wish I had a little bit more support with.
Yeah. Yeah. Dr. Tubman, I'm going to give you the last word on this one because you hear from so many people about, I wish I had. So maybe, and this, by the way, is going to have to be our final question, unfortunately, final response.
I hear exactly what Kaya and Melissa were mentioning. I wish I heard about this sooner, really, when it comes to a lot of the supportive care services, right? So whether that be social work, psychology, rehab, just knowing that there are supports available, because often we just don't know how to access them. Linking back to what Kaya mentioned, I think it's really important to have an advocate, a support person there with you. This links back to the earlier question, because it can be very vulnerable, especially when you're feeling unwell, to advocate for yourself in those moments for the services and support that you need.
Yeah. Thank you. And I'm afraid we're going to have to wrap it up there, but there's still a number of questions. For those of you who submitted these the questions, A, thank you, but B, know that Colorectal Cancer Canada will be following up with all of you to ensure that you feel comfortable in getting the questions that you've asked answered appropriately. So our thanks to Dr. Tuttleman, Dr. Wildgoose, Kaya, Melissa, and Amanda, who wasn't able to join for the Q&A session, very, very much for joining us today.